welcome to Consensus or Controversy. Clinical investigators provide perspectives on the current and future management of ovarian cancer. I'm Dr. Kathleen Moore, and I'll be moderating this exciting session this morning. This slide shows our faculty this morning, just to introduce them briefly. This is starting on my far right, this is Dr. Joyce Liu from Dana-Farber Cancer Institute. To her left is Dr. David O'Malley from The Ohio State University, and to his left is Dr. Mansoor Mirza from Copenhagen University, so he gets the award for traveling the farthest distance to join us today. Here are our relevant disclosures. And me. And these are the disclosures of our video participants, who you will meet on video in a moment. This program will contain discussion of non-approved uses of agents and regimens. Please refer to the official prescribing information for each product for approved indications. So this is where we're heading this morning. We're going to start out with Dr. Liu discussing the upfront treatment, including primary maintenance. That will be followed by Dr. O'Malley, who will talk about the role of immunotherapy in ovarian cancer. I will follow and discuss novel strategies for relapsed refractory ovarian cancer, and then we'll finish the morning out with Dr. Mirza addressing diagnosis and management of adverse events associated with available treatments for ovarian cancer. In order to make this meeting more relevant to participants, a survey of key clinical questions was conducted, and the results will be shown and discussed during the program. Dr. Love also interviewed Drs. Deborah Armstrong, Flor Bacchus, Rachel Grisham, and Ruthu Salani, non-faculty survey participants, on their perspective about a number of key clinical issues. Video excerpts from those interviews will be featured throughout today's program as well. So we're going to start off with module number 1, current upfront treatment for advanced ovarian cancer. And we'll hear in a few moments from Dr. Liu, but we're going to start off with a little video vignette here that you can see discussing the integration of bevacizumab into neoadjuvant therapy and the quality of tissue specimens to inform neoadjuvant therapy selection between Drs. Love, Armstrong, and Grisham.
Good morning, everyone. I'm Neil Love from Research to Practice, and a special thanks to our consulting faculty who worked with me over the last couple weeks to develop some questions for the faculty on the stage to consider, beginning with a brief look at neoadjuvant systemic therapy.
In this era where we're treating a lot of patients with neoadjuvant therapy, I think many of us are trying to figure out the best regimen to use in that situation. The first question is the use of bevacizumab. And I would ask the panelists, how do you decide about who to give bevacizumab to, particularly in the neoadjuvant setting? What I've kind of moved toward is not giving bevacizumab before interval debulking surgery, but I do look at the Kellam score, because the Kellam score actually is predictive of who benefits from bevacizumab. And if the Kellam score is low, then I will use bevacizumab in the adjuvant setting after the interval debulking and continue it in the maintenance setting. And Neil, part of the reason I'm asking that is because the community docs do that all the time. They didn't get Bev with chemo, but then afterward they give them a PARP inhibitor and Bev.
There's a couple different important questions that come up here. And one of them relates to how important the molecular profile of the tumor is now for determining a patient's subsequent maintenance therapy. And when someone is undergoing neoadjuvant chemotherapy, I think it's really important that we think about the quality of the tissue specimen that is collected before starting that neoadjuvant chemotherapy. And so it's interesting to see whether practices are prioritizing getting that high quality tissue specimen before starting neoadjuvant chemotherapy or not, and what factors go into that decision.
So we'll spend a few minutes just discussing this. We could spend an hour discussing neoadjuvant chemotherapy. We're going to just spend a few minutes discussing this with a couple of our faculty just to start off the morning. And so I'm going to get a perspective, kind of a U.S. perspective, and then a representative European perspective, since we actually have a global panel with us today. We're fortunate enough to have Dr. Mirza representing the world, and then I have two people representing the U.S. So representing the world, Dr. Mirza, no. Can you just give us perspective? Because I think there may be some differences, honestly, between practices in the U.S. and practices outside the U.S. with neoadjuvant chemotherapy and the use of bevacizumab. Can you sort of kind of give us your take? You give us your take. You don't have to represent the rest of the world, but.
Thanks so much. Let me start with, I think there was a very nice remark by Dr. Grisham about molecular profiling. That is the first thing you need to do. Get a good biopsy, get the BRCA testing and HRD testing to know what is happening, so you have all that information while you are starting with your neoadjuvant therapy within the next 3 to 4 weeks. Regarding bevacizumab, it's a little bit difficult question because you have 3 cycles and you don't want to give it the cycle 3. So do you want to give in cycle 1 and 2 and then pause? And you don't know if it is needed because, as Dr. Armstrong said, that there is also, we have now CALM score, which may tell us in the adjuvant setting where we would like to have. So there is a different opinion. Typically what happens if there is a huge bulk of disease, we may decide to add bevacizumab in that case, but this is not a standard in the global world, if you say it like that. But if it is stage 4, quite massive disease, I would be adding bevacizumab in that case for the first 2 cycles, 3rd cycle without, before the surgery.
Great. Why don't we go to Dr. O'Malley for kind of your perspective, and then we'll move to the next video.
Yeah, I mean, this is, I've become a big believer with Harder's Apollo 1 sub-analysis, the low risk versus high risk, and there is no low risk advanced ovarian cancer. So I give Bev to almost everybody in the adjuvant setting. Ironically, still in the neoadjuvant, I still debate it. Those patients with large pleural effusions, very symptomatic, I tend to start with Bev. Now, 6 to 8 cycles, I would say within the standard of care, 3 to 4 prior to interval tumor reduction, 3 to 4 after. So I tend to give 4 before surgery so they get 3 cycles of Bev if I'm utilizing the Bev, holding at that 4th cycle.
And then before we move on, Dr. Liu, Dr. Armstrong mentioned that she uses the CALM score. Can you just maybe comment on that briefly, what it is, and do you use it, or do you think it's useful in this setting?
I think CALM is really, it's a very interesting score. It looks at the rate at CA-125 decreases as you give chemotherapy, and there's a website where you enter in sort of the dates and what the CA-125s are, and it can sort of predict for that responsiveness to chemotherapy. There's been a lot of studies. It's been looked at in a lot of the large phase 3 studies and has potential prognostic value. I think the predictive value is something that, retrospectively, it looks like it may predict for the value of adding Bev. It may predict for the value of adding PARP inhibitor, but those haven't been prospectively validated yet. And I think that's a part where we really should drive that forward so that we understand, can we bring CALM into practice with the confidence of knowing we validated prospectively?
Yeah, thank you for that. Okay, we're going to move on to our next video discussion between Drs. Lev, Solani, and Armstrong.
To continue, we ask your thoughts on primary maintenance therapy and how that varies based on genomic status and other clinical factors. We're also interested in new techniques that might be useful clinically, such as the use of cell-free DNA, but let's begin with some thoughts on key issues for you to address in primary maintenance treatment.
I think with the BRCA mutation carriers, the role of PARP inhibitors is very clear. I'm curious, though, if folks are adding bevacizumab in addition to the PARP inhibitors, since we have some data showing that combination does show some benefit. And then if you're doing that in the HRD population, where we saw the PALA-1 study showing some benefit in that population. And then for the HRD test negative patients, are you using bevacizumab? Are you using niraparib, which has an FDA label in that? And I have this discussion with patients myself, talking about kind of pros and cons and exploring both options.
The cell-free DNA, and we're looking in particular at the circulating tumor fraction of cell-free DNA, has been quite exciting in many areas of oncology. I think we're just trying to figure out how to use that in GYN malignancies, basically replacing a biopsy. And the other is looking at response to therapy, And the third is the presence of minimal residual disease. And I would be interested to know how the panelists think that we can best use cell-free DNA or ctDNA. And I would like to point out that there's going to be several presentations about ctDNA at this SGO meeting.
So again, another topic we could spend an hour on, but we're going to spend 3 minutes. And I'm going to start actually with Dr. Liu, because you and I have been talking about ctDNA all meeting, and so I know it's hot on your brain. So can you give sort of just a brief overview of what the current practice is and what you think the hope is for ctDNA?
Yeah, so the current practice is that we don't know how to use ctDNA within the ovarian cancer space. I think that's pretty clear. I think the tantalizing thing is, can we use ctDNA to detect early recurrences or sort of changes, what times when we should change therapy? And I think one of the challenges I've had with thinking about ctDNA is we've always had CA125. We know even if we see early recurrence, there's not something we necessarily do that changes outcome. So really the tantalizing part, or the thing that we have to think about with ctDNA, is if we detect early sort of recurrence, how are we going to leverage that information to actually change what we do and improve outcomes for our patients?
Yep, Dr. Miley.
I agree. I'm not that excited about telling somebody 6 weeks or 12 weeks early that we're going to need to start chemo. But I do think is interesting, particularly in this next era of ADCs, at the completion of the 6 to 8 cycles of adjuvant chemotherapy, if somebody had a persistence in their cell-free DNA, they had persistence in that, would that be that opportunity to add in a targeted ADC to help improve our curative intent, in a maintenance type strategy, consolidation, whatever word you want to use. So I think that may be the opportunity for us to say we're going to change therapy or add on additional therapy like we're talking about in the maintenance setting. That to me is the most exciting opportunity, or early stage disease, which would be a harder trial.
Right, or if we see early recurrence on a PARP inhibitor, that's a time when we need to know to switch.
Yeah. Again, we could talk about so many things for so long. I wanted to get to this before we ask Dr. Liu to give her didactic lecture for this morning. This is just one of the cases went out and we all had to provide answers. So we'll just kind of go through one and get a couple thoughts before we move on. So this is a 65-year-old patient who is stage 3C ovarian cancer. She's received neoadjuvant carboplatin, paclitaxel, and bevacizumab with excellent response, R0 resection, and she has a BRCA1 mutation. And so all considerations aside, this is what the panel decided for her for therapy with, I think the only difference is Dr. Armstrong only using olaparib, the rest of the panel continuing olaparib bevacizumab for 2 years. Dr. Mirza, any comments on this bevacizumab versus olaparib in a BRCA?
Yes. Well, people will say they are so sensitive to PARP alone, and we could deal with PARP alone, and I do understand that because the data from Paula-1 does not directly tell us that addition of bevacizumab on PARP is increasing, but we do know that this is a high-risk population. This is neoadjuvant, and in neoadjuvant, I would see the benefit of bevacizumab post-surgery after 3 cycles is important. So I would rather combine the 2 drugs if there is a stage 4 disease or neoadjuvant, and then because of the high risk. Otherwise, I could have dealt with single-agent PARP as well. If it was the case.
Yeah. And then just real quickly, this is the second case, kind of same thing, but she's BRCA wild type, but HR deficient or LOH high. Dr. O'Malley, any comment on pretty much we all agreed, olaparib, bevacizumab for 2 years in general. Any comments on, we seem to agree. There's not a lot of disagreement there. Any discussion? Would you ever use single agent niraparib here instead?
Yeah, I think it's a reasonable alternative. It's a very reasonable alternative, but because you've started the Bev for me, I'm going to continue that. And there's data with regards to rapid Bev, which is not approved in the U.S. So I think in this instance, I tend to go with the label, with olaparib Bev, particularly the overwhelming Paula showing benefit.
All right. Well, let's move on to our first presentation of the morning. And I'd like to welcome up Dr. Joyce Liu from the Dana-Farber Cancer Institute to talk to us about upfront treatments in ovarian cancer. Dr. Liu, take it away.
Right. Thank you so much. And thank you for everybody who made it in person and everybody online and those of you who were at the disco party all night long. So I'm going to talk about current options for upfront ovarian cancer, predominantly looking at BRCA and HR testing, as well as how that informs PARP inhibitor maintenance. So why do we test for HR and why do we test for BRCA in ovarian cancer? So we've known for many years clinical testing for germline BRCA and other genetic susceptibility genes has implications for cascade testing for our familial risk. But what we've learned in this era of PARP inhibitors is that somatic tumor testing for BRCA and HR deficiency has clinical implications for our decision making. And to the right is the original sort of slide that accompanied the original article in New England Journal 15 years ago that really highlights the immense synergistic and synthetic lethality potential of homologous recombination deficiency together with PARP inhibition. A reminder, right, BRCA mutations and HR deficiency are common in epithelial ovarian cancer, and they don't occur just in high-grade serous ovarian cancer. So BRCA1 and 2 mutations occur across the spectrum of epithelial ovarian cancer subtypes, excepting mucinous histologies. And 50% of our high-grade serous ovarian cancers do have evidence of molecular reasons for HR deficiency. Now, much of that is BRCA-related. 5 to 6% is somatic BRCA mutations, and then there's a number of other alterations that suggest that HR deficiency is present. How do we test for homologous recombination deficiency? Now, this is a big sort of issue for us, right? Homologous recombination is one of the primary pathways for cells to repair double-strand DNA breaks, so you get this genomic scar when it's lost. And all of our current commercial assays of HR deficiency use this genomic scar, these patterns of DNA damage, to indirectly predict whether a cell is HR deficient or HR proficient. That's what we've used in our phase 3 studies. That's the table in the right upper hand corner. You know, the Myriad My Choice and the Foundation 1 assay, both are using genomic scars. That's what we've looked at. But these are imperfect tests. They're indirect measures. And we keep thinking, is there a better way for us to look at it? We've looked at additional proposed assays of HRD. Can we look at the genes that are mutated in the homologous recombination repair pathway and look at that? Unfortunately, that really hasn't panned out in a general sense so far. Can we look at functional assays of HRD, looking at RAD51 foci formation, for example, which is a much more direct way to look at it. And these are, I think, growing, but we're just not quite there yet that these are ready for prime time. So how does that inform how we think about PARP inhibitor maintenance? So I'm a kind of I have a simple brain, so I have to break this down into simple buckets. We have patients with BRCA mutated tumors. We have patients with BRCA wild type and HRD test positive tumors. And then we have patients with BRCA wild type and HRD test negative tumors. So if we think about these large buckets, then we have at this point a number of trials that have informed how we think about them in this setting. There are additional studies. There have been studies done in China. I'm not going to talk about those today because they use a different way of looking at HRD. And there are non-randomized studies like Ovarian that look at niraparib plus bevacizumab. So let's start with the patients with BRCA mutations. As you heard Dr. Solani say, this is where we know. This is the slam dunk. Patients with a BRCA mutated tumor should get PARP inhibitor monotherapy maintenance. This is the monotherapy data. Sorry, not monotherapy. They should get PARP inhibitor. And you can see here's the monotherapy data, hazard ratio of 0.3 to 0.4 for progression-free survival. But really what has been really rewarding and comforting is looking at the 7-year median follow-up from the SOLO-1 study led by Dr. Moore, and you can see here that overall survival at 7 years, those curves are separating. And that median OS is 75.2 versus not reached, p-value of 0.55. And really, when you look at the time to first subsequent therapy, that's 2 years of olaparib. 7 years out, 5 years later, 45.3% of these women have not received a next line of subsequent therapy. Those are patients probably who haven't had recurrent disease. That's amazing and transformative. These are patients where we have changed the natural history of this disease. It is, as I said, transformative. We see the same thing in the PRIMA study. Niraparib maintenance, we only have 3.5 years of follow-up right now in terms of PFS. To the left, you can see the HR deficient population, which includes the BRCA mutated patients. To the right, you see that subset of BRCA mutated tumors. And again, what we see is an improvement in PFS. This is a higher risk population. That's why this is not looking at the same length of time as SOLO-1, but still you can see after 3 years, we still see that really large separation of these curves. How about adding it to bevacizumab? Does that work if your patient's already on bevacizumab? That's the PALA-1 study. Again, you can see here, median PFS on the left side, that's the primary analysis, stunningly positive, hazard ratio 0.3, just like in the PARP inhibitor monotherapy. And then the 5-year OS analysis showing that median OS is still sort of separating, hazard ratio 0.60. But does this study answer the question of should you do bevacizumab plus PARP or PARP alone in patients with a BRCA-mutated tumor? And the question is sadly not. And this figure I got from Dr. Moore, the very sad man who has missing an arm, because this trial is missing an arm. How about if we go to patients with a BRCA wild type and HRD test positive tumor? So these are the trials that have informed how we think about this so far. And the big trials are PRIMA, looking at HR deficiency by the Myriad assay, and Athena Mono, looking at HRD deficiency by the Foundation assay. And you can see here in the primary analysis of PRIMA, the curves separating, the median PFS, hazard ratio 0.50, very clinically significant. And in 3.5 years of follow-up, you see that continued separation of the curves. But one thing I'll point out to you is this is not the same as the patients with the BRCA-mutated tumors. The curves remain separate, but they're still going down. We're not seeing the same plateau that we saw in patients with BRCA-mutated tumors. We have more work to do here. And again, in Athena Mono, again, seeing that separation of the curves, but they are going down. What we don't know from these is the OS outcomes. So we have more data to come for these studies. How about adding this to bevacizumab, PARP inhibitors to bevacizumab? Again, the PALA-1 study tells us that we do improve median progression-free survival. The primary analysis there on the left, the hazard ratio of 0.43. When we look at that final OS analysis with 5 years of follow-up, we see that there's nominal improvement in terms of numerically for the OS, that hazard ratio of 0.71 that does cross the confidence interval of 1, but again, we don't know how that looks compared to PARP alone. We are missing an arm in PALA-1. Finally, how do we do in patients with BRCA wild type and HRD test negative disease? And we know here is where we have the most challenges when we think about PARP inhibitor maintenance. These are the PRIMA and Athena Mono data from looking at this. And if you look at that primary analysis, the median PFS was a 3-month difference and a hazard ratio of 0.68. But look at that 3.5 year of follow-up. The point estimates are preserved, but those curves that we're separating now are starting to come together with our longer follow-up. And Athena Mono, similarly, we see the curves separating and starting to come together. And Dr. Mirza has taught us all about alligator studies as well as banana studies where the curves separate and come together. And I'm sorry, but Mansoor, when I look at that, that looks awfully like a banana. And then how about, can we add this to bevacizumab? Will that help in our patients with HRD test negative and BRCA wild type disease? And here from PALA-1, we can see both the primary PFS analysis and the OS analysis that adding PARP inhibitor to bevacizumab in patients with BRCA wild type and HRD test negative disease does not improve outcome. We are not helping people by doing this. Ovario, I'm just going to skip over for time, but it's basically saying that we can give niraparib and bevacizumab together. That's feasible. Is it better? We don't know. Is it giving us something extra? We don't know. This study is a single-arm study, so it doesn't tell us about that. So in summary, if we look at frontline maintenance, where are we? What's still ahead? I would say it's really important. We test for BRCA mutations. We test for HRD status. If you have a patient with a BRCA mutated tumor, these patients should get PARP inhibitor. If they're not getting bevacizumab, they should get a PARP inhibitor. If they're getting bevacizumab, they should get a PARP inhibitor. Give them a PARP inhibitor. For patients with a BRCA wild type and HRD test positive tumor, I think what we know is that they do get PFS benefit, and that PFS benefit is is substantial, but what we don't know yet is that going to lead to OS benefit? We have a trend within the addition to bevacizumab, but we don't know how that compares to monotherapy. And for patients with a BRCA wild type and HRD test negative tumor, we have so much work to do. We have a modest PFS benefit with PARP inhibitor, but we don't know that we have OS benefit. And if we add PARP inhibitor to bevacizumab, that is not helping us. Still to come, OS for monotherapy, understanding PARP inhibitor versus PARP inhibitor plus bevacizumab, and then Dr. Malley is going to solve all of our problems by telling us how immune checkpoint inhibitor is going to save the world. Thank you all.
Good job. Great. Thank you so much. That was wonderful. All right, we're going to move on to the second module, which Dr. O'Malley is so excited to talk to you about. And it is exciting to talk about immunotherapeutic strategies for advanced ovarian cancer. But let's again start with one of our video vignettes, discussion between Drs. Lev, Solani, and Grisham. And we'll have a little discussion.
Dr. O'Malley is about to review a number of interesting investigative approaches, including the use of immunotherapy, but our consulting faculty is also interested about current management of recurrent disease, and particularly in light of the FDA decision restricting the use of PARP inhibitors in this setting.
I think the FDA withdrawing the label for PARP inhibitors in the second line for patients who are platinum sensitive, not BRCA mutation carriers, was a little surprising to many of us. And I'm wondering if you have a patient who maybe didn't qualify for PARPs at the initial time, whether it wasn't around or whether the patient just opted not to, but now has platinum sensitive disease. How do you have that discussion with the patient, knowing that there was the withdrawal from the FDA and withdrawal from the companies after this subgroup analysis, which was not a statistical endpoint?
Something that comes up as a common question is for those patients with recurrent disease that are currently on PARP inhibitor maintenance following complete or partial response to platinum-based chemotherapy for recurrent disease, when do you stop the PARP inhibitor? So this is something that nobody has a clear answer on. Of course, in the initial clinical trials, that PARP inhibitor was continued indefinitely until time of progression, but we're increasingly concerned about that, given concern for cumulative toxicity and then, of course, risk of MDS or leukemia, which can be particularly a higher risk in those patients that have a BRCA mutation. In my practice, we do now generally stop patients' maintenance PARP inhibitor in the recurrent setting at 2 to 3 years, but it'd be interesting to hear what others are doing.
So very provocative clinical vignette. We actually only have one clinical video vignette for this pod section, so we can spend a little more time discussing some of these important questions, and then we can maybe touch on some of the immunotherapeutic strategies. But I'm going to start, sorry to put you back on the spot, Dr. Liu, but I'm going to start with you, and then we'll get some opinions from the panel. What is your take on the withdrawal based on the suggestion of detriment in overall survival with use of PARP in the recurrent setting, and how does that impact your use of PARP in the recurrent setting?
Also, I think in the recurrent setting here in the US, we don't have access to PARP inhibitors after the withdrawal outside of the patients with BRCA mutations who haven't received a prior PARP. So for an impact of practice, it's not in general something we can offer patients without a BRCA mutation. When we think about, what I think it's a very complicated question. I think we have to be careful. There are probably patients who benefit from PARP inhibitors still in that maintenance setting, but we don't know who they are. And I think that, when the first studies came out, I was like, I don't believe this, but all the studies have, had hazard ratios greater than 1. And I think it means that we have to ask the question, is there a group of patients who we are harming by giving them PARP inhibitors as recurrence maintenance therapy all the way through progression? And so I think that's the question I keep asking myself, and I feel like we have to figure out how to answer.
Yeah, why don't I go down the line, Dr. O'Malley?
Well, I'm really interested to hear what Dr. Mirza says, because Europeans did not poll, right? So I do believe there's a patient that benefits. In the clinical, if we look at the Ariel 3 data and a paper we recently did with regards to extreme responders, that the clinical features are more important than the molecular testing outside of BRCA and RAD51C or D. So if you get a complete response based on CA125 and or CAT scan, okay, that those patients seem to benefit the most in the platinum-sensitive space. So if I have an HRD negative patient and they didn't get PARP inhibitor in the first line, but they get a wonderful response in the platinum-sensitive, I will have that discussion. And it still is listed in the NCCN guidelines, so you still have the ability to fight with the insurance company to get support. But I do have that conversation with the patient with regards to the risk and benefit. And I'd love to come back to the length of therapy once we hear from Dr. Mirza.
Yep.
Thanks. Well, if I put heart against heart to FDA, I'm completely against that decision. And you know our understanding, and I had discussions with consultations with European Medicines Agency, which is much more pragmatic and did not change the label. And there are reasons. Reasons are, first of all, that the data we had at that time was incomplete, inconsistent. The data was taken from the NOVA trial where we did not have reported how many patients crossed over, what they received post progression, and we didn't have overall survival data completed. And on that, in a non-analytical endpoint, to take one level, 1.0, and say that this is detrimental, I do not agree to that. And I'm very satisfied that European Medicines Agency did not change their decision, giving benefit of doubt for our patients. I think it's important. You mentioned it very nicely. There will be patients who are PARP naive and enter the platinum and the relapse. What are you going to do? Are you not going to treat these patients with PARP inhibitors? No, I think that would be very much troublesome. So fortunately, I'm on the other side of the pond and I can prescribe patients with PARP inhibitors. The question is how long, and that's a very important question which Dr. Grisham also has mentioned. When you look at these patients who have got multiple relapses and multiple platinum therapies with DNA damage, and on top of that, PARP inhibitor for a long time, there is a risk of MDS and AML. What we do, I talk to my patients after when they have had 2 years, 3 years of therapy, and try to discuss and suggest them to stop therapy. But label says that you can continue until progression, so it's a decision between patient and us to do that.
You know, that same paper that I wrote with regards to extreme responders, Deb Armstrong actually wrote a very tough letter to the editorial question on the high AML rate, which hit almost 15% in those extreme responders. Yeah. It was a very good question, and I'm so glad she asked it, because it allowed me to dive down to every single patient who had AML or MDS and look at those clinical characteristics. And where did we see? Very consistently, multiple prior lines of platinum therapy and beyond 3 years of therapy. By definition, extreme responders, we took us 2 years. So 3 to 4 years of therapy. So I had the exact same conversation at year 2 and 3. But a lot of these patients are, especially in the recurrent setting, saying, I have a deadly disease here. This is working. I'll take my risk. Now, if they have a complete response, if they're really, I'm not sure they're benefiting at that point, I really do encourage them to discontinue therapy, and I know there's no data, at that 2 to 3 year mark.
One last comment.
I'm just going to make the quick comment, though, that, I mean, AML and MDS risk is not, I think, the only thing that may have contributed to decrement.
Exactly.
And I think that we owe it to patients that we're honest, and I know that you are, when we're talking about PARP inhibitor maintenance in the recurrent setting, where our data do not support that there is OS benefit, and maybe even there is a question, could there be OS detriment, and that we have to discuss that component of it.
Oh, and we do.
And I know you, that's what I'm just saying. I just feel like we have to be clear about that.
The potential detriment is really what you said. You know,
it's possible.
That is something we need to consider, and that's why I look at those clinical features. I'd really like to dive in that more. And we're going to see some more data from some of the phase 3s here shortly, diving into that question more, and I hope that could help answer.
I think the most complete analysis of past progression therapies, what kind, which PARPs, which line, and complete OS data comes actually from the NORA trial, which is which is in the Chinese population, right? But there you don't see that. On the contrary, you see a non-analytical benefit. So I think it's a very open question. I do agree that after 3 years, we should discuss with the patients. I will not take a decision to stop. I will discuss it. I will give an option that my suggestion is to stop the therapy. But if patient is not willing to stop, I cannot do that.
I think we have to have the discussion when we start.
Yeah, I gotta move on. See, this is hard. This is like
Controversy.
This is like an hour-long discussion. But let's just get a couple of these in before we move to Dr. O'Malley's presentation. This is outside of a protocol setting, and we kind of just discussed this. We were asked, would you administer a PARP inhibitor to a patient with relapsed ovarian cancer? This is the discussion we're having. And here we do see a little more discordance amongst the panel, some really responding, you just heard it. Dr. Liu, you said maintenance after response only in BRCA and no prior progression on PARP. Dr. Mirza is all regardless of HRD. Completely opposite, and I think that reflects regulatory approvals. This is sort of the regulatory approval in our respective countries. Dr. O'Malley, only if no progression on prior PARP. So I think we're increasingly, I think I said the same thing. We're increasingly understanding there's a difference between those patients who progressed after PARP, progressed on a PARP, and that seems sort of obvious to say out loud, and whether or not that has some significance in terms of what we prescribe in the subsequent lines of therapy. Let's move to the second question. And this is, again, outside of a protocol setting. In what settings would you administer a PARP inhibitor as a component of later line treatment for patients whose disease has progressed on or after first line maintenance with a PARP inhibitor? And again, this is where, unlike the first questions where we all agreed with one another, here there's a lot of clinical equipoise. Dr. Grisham said never. I kind of made up something about disease-free interval based on no data, which I do a lot. Dr. Mirza is only in a BRCA. Dr. Liu's being more thoughtful and wrote a complete sentence. None of the rest of us did. Any comments? Why don't we go, Dr. O'Malley and Dr. Liu, why don't you kind of comment on your responses?
Well, I think the PALWA data is really started to show that a progression on PARP versus after PARP are two different patient populations, and we continue to see data. So for me, I'm not switching PARPs. If they haven't progressed and they stopped at their 2 years of therapy and then they recur in the platinum-sensitive space, I probably would encourage consideration of another PARP maintenance.
Yeah, Dr. Liu.
For me, I think, and Katie, I think that I'm just much more wordy than you are, but I think that we have something that's very similar, and it's really, I think, again, who do I think PARP is most likely to benefit, and what's that sort of component of potential risk?
Yeah.
And if I may, I would say that we are not there yet. We did the trial, and that was the time when we had PARP only in the relapse setting, and patients were progressing under PARP. So that's a difficult answer to answer until we have more data.
Absolutely. We need more. That's why we have clinical trials. All right, now Dr.
Now I can stand. All right. I was so excited.
Rise and join us. Yes.
Joyce, Liu, and I almost never disagree. And Joyce, I listened to your entire presentation, and I don't think I disagreed at all, except when you danced around curative intent in our upfront ovarian cancer. You wouldn't say it. What was the wording you used? We have a significant change in disease trajectory or something. It was very... It was
transformative.
No, it was something else there. It was very Harvard, like dancing around, and it sounded... I can't say it. I'm from the Midwest, and so I think as we look at this, we're going to go through a little bit to say, and what we're talking about here, and we need to start changing. I believe this is my opinion. We need to start changing the dialogue from hazard ratios to what is the opportunity for curative intent in our advanced stage ovarian cancer patients. Yes, hazard ratio is an important statistical analysis. Yes, we need to talk about what are we going to do. Median progression-free, median overall survival just helps us tell the story, but it really doesn't show the difference. The difference is how many more patients are we curing with the therapies in advanced ovarian cancer. We're going to go over that a little bit. It's actually a slide I adopted from Dr. Moore. And you're looking at the different paradigm shifts over time. Obviously, the first big shift was 2011 with Bev. Saw another marked shift in 2018 with the utilization of PARP inhibitors. Further during the next 3 to 4 years, further shift with combination PARP and Bev, as well as PARP inhibitors in all-comer population. Are we now at paradigm shift number 4? With Duo and some of the trials we're going to read out. And that really is the question over time. Dr. Liu, this is exactly, I think it's a drop the mic. Are we going to use PARP inhibitors in HRD positive population? At this point, if you're not using them in BRCA, you're not adhering to the standards of care. I'll just say it out loud, okay? And if you're not using an HRD, unless you have a really good reason, I'd argue you're not adhering to the standards of care, okay? HRD test negative, a different story. So we have clear benefit there. How are we going to change and improve this, okay? Now, you saw this in Joyce, we're friends. Do you mind if I call you Joyce? Is that okay, Dr. Liu? Okay. So I'll go back and forth. I don't want to be disrespectful, but we are very good friends. So we have some missing arms that are going to continue to get answered with regards to the arms of bev-olaparib versus bev alone versus olaparib alone, or adding additional bev to PARP inhibitors in these additional trials. And we'll get those this year. But should we and can we improve, particularly in that HRD test negative, but really we're not curing anywhere close to everybody with advanced ovarian cancer, even if they have BRCA. Probably close to half of them. Okay, HRD test positive in Apollo 1, maybe close to half of them. It's a little bit hard to tease out some of that data because it's such small numbers in the non-BRCA patients. But if we add immune therapy and we create more if we're able to, by creating more neoadjuvants with our PARP inhibitors or with our chemotherapy, is immune therapy going to help? Or are we going to, by activating the STING pathway, make our patients more sensitive to PARP inhibitors? Now, anytime you have cell death, you're going to have neoantigens, right? So anything that kills cells, we think, will then create a greater immune response. The more we can kill our cancer cells, the more we're hopefully going to benefit from immune therapy. And really, ovarian cancer should benefit from immune therapy. I could have showed you 50 slides on the preclinical with regards to why immune therapy would help PARP or PARPs to help immune therapy. The reality is I'm a clinician, I'm a clinical investigator. And so the one paper that really, or trial, now paper, really made me optimistic was the Mediola trial. And this was in platinum-sensitive treatment with 2 really arms. There's been a couple Mediolas. This is the non-BRCA arm trial. And when we looked at olaparib durva versus olaparib durva bev, okay? And we looked at those non-BRCA patients, and you see there on the right are the doublet on the top and the triplet waterfall plots on the right. Looking at a treatment phase and the triplet, we had an 87% response rate across all molecular subtypes. Very small numbers, but gave me a lot of confidence that Duo would be wildly positive. So let's look at Duo more closely. All right, basically a 3-arm trial, but it's really arm 1 versus 3, which was chemotherapy, arm 1. The other 2 were placebo, versus arm 3, the purple at the bottom, which was the durva and olaparib, okay? The arm 2 is really the relative contribution of what the durva would be added, and not the formal primary analysis, but a key secondary analysis. And what do we see in that primary first analysis, the non-T-BRCA HRD positive? Remember that BRCA patients did not go on to this analysis. We see clear benefit. But when we think about where we are on a bev-olaparib, it calls into question how much additional benefit the durva is adding. And we see the intent to treat population. You see those curves coming a little bit more together. I do want to say for the audience, I'm going to go through these slides very quickly. I included all of them for reference. They're all in your packet and they will be included, but just for completeness sake, I did want to include them. This is with the second arm, Durva arm in. You see it kind of falls in between the other two arms. As we look more closely at the HRD status, you see again, this is the side-by-side of the HRD test negative versus HRD test positive. HRD test negative, we see a banana curve. HRD test positive, we see some separation and some flattening out of those tails. And with the arm 2. So, we just changed the slide. This is actually HRD test negative. There's a typo, I apologize. But as we look here at Powell on the right, this is Powell 1, so Bev versus Bev-Olaparib, you see there's no benefit in that group of population. And we have that in the duo O. As we bring those together, is there a separation? Now, we all know cross-trial comparison is not valid, but we all do it. Is there a difference here? I don't know. Or is this a single arm all coming together? So we're going to answer some of these questions here very shortly. I updated this immediately before this talk. Actually, my slides were late, so it literally was immediately before this talk. And you see now that clinicaltrials.gov has been updated. First is going to, has been now projected at the end of this month, and actually in a week or so. Key link, both of those allowed for Bev, and that's what the red arms, August. And now Athena combo, they say December, though, I'm excited to see that data. All of this data will be within the next year answering this question. So, are we changing the paradigm? Are we changing what we're going to do, particularly in HRD test negative? Are we going to have the opportunity to cure more of those patients? Because our interventions right now are improving survival, but not changing. But how about the role of immune therapy beyond the first-line therapy into the recurrent or platinum-resistant space? Again, I include this slide for completeness. This is the phase 2 and phase 3, looking at trials in the platinum-resistant space, single-agent IO or in combination. And as we look more closely at the ongoing trials, which will somewhat lead us to answering some of these questions. For example, GY009, which has already been reported. The red X is through the PLD Atezo arm. And we see here, we see some separation, but clearly not a marked difference, not statistically or really clinically, in 009. So how do we improve upon single-agent IO therapy? I shouldn't say single-agent. Checkpoint inhibitor plus chemotherapy. Well, how about the next generation? Artistry 1, which is with nemvaleukin, which is a next-generation IL-2. For those who have given high-dose IL-2 for melanoma, this is not that. This is not anywhere close. You do not see the side effects you see with IL-2. And so we have a phase 3 trial, which is looking at a 4-arm trial, which is recently had been announced to be completed enrollment, but now we just heard, and I can officially say this, I got permission from the sponsor, that is now going to be open up to 48 more patients and looking at just arm 1, which is nemvaleukin plus pembro versus investigator's choice chemotherapy with an overall survival benefit. Overall survival is the primary endpoint. So I just want to thank you for your time. Lots of interesting questions still to be answered. Appreciate it.
Thank you very much, Dr. O'Malley. And that's exciting about Artistry 7. I think maybe we'll kind of loop that into our conversation again, so we can talk a little bit more about that interesting study. But let's move on to the next section, which is incorporation of novel therapies into the management of relapsed and refractory ovarian cancer. And I'll be giving a lecture here. But first, we're going to start off with some more videos between Dr. Love, Armstrong, and Grisham.
The use of antibody-drug conjugates has exploded in every corner of clinical oncology, including gynecologic cancers, where tisotumab vedotin is now regularly used in cervical cancer, and the folate receptor alpha-directed ADC mirvetuximab is now a primary consideration in platinum-resistant recurrent ovarian cancer.
I think this is particularly a good question to ask because I think Katie Moore will be able to feed in on this. So I would ask the panel, particularly now that most of the tumor next-gen sequencing will include folate receptor alpha testing. And that if we do that on the initial tumor and somebody recurs at a later date, do you repeat it? Is it expected to change with disease progression? Could a positive test now be negative? Could a negative test now be positive?
I think when we first started using mirvetuximab, there was a lot of concern about how we were going to be able to manage the potential ocular toxicity. Personally, I use the ophthalmologic form that's available on the drug website and just print that out, give it to my patients, and have them complete it with the ophthalmologist prior to their visits that are mandated every 6 weeks while on mirvetuximab. Our community ophthalmologists appear to be very comfortable completing those forms and willing to get the patients in quickly so that they can have these exams done every 6 weeks. But I live in New York where we have a lot of doctors. And so I do wonder if that's challenging in other regions of the country for patients to be able to efficiently have that ophthalmologic exam done every 6 weeks while on mirvetuximab.
Great. So we'll have a little bit of a brief discussion. I'm going to answer the first question because I can. Just the first question that Dr. Armstrong posed about repeat testing. And I'll just tell you, early on in the development of mirvetuximab, we did a study where patients were enrolled based on archival tissue testing, but they got it on treatment biopsy or proximal biopsy, and then a biopsy on progression. And it was only about 30 patients, but we looked at correlation. It was highly correlated, about 80% correlation between the archival and the pretreatment biopsy, which is why we move forward with the phase 3 study saying you could use archival. That being said, number one, I wouldn't say you must re-biopsy as a rule. That's true. But I definitely have had at least 2 patients now who are negative on their archival testing, and they ended up getting a surgery or a biopsy or something at the time of recurrence. And there was some time period between the two. And so I resent molecular testing, and they were positive on the subsequent testing. So whether or not it changed or the tumor that had grown back was just the clones that were positive and I biopsied something different at baseline, we don't really know that natural history. But it can happen. So I think we still are going to have to follow that over time to see whether or not we should be recommending rebiopsy, but right now we don't. So what I want our panel to comment on, and then we're going to move to a little bit of discussion on ILD in the next video, is what are your thoughts on rebiopsy? And then what are your thoughts? And Dr. Mirza, I'm going to throw this to Dr. Mirza and Dr. O'Malley. Dr. O'Malley lives in Ohio. I live in Oklahoma, rural states, not as many doctors as New York. How are we dealing with the ophthalmologic requirements in the US, and then what's the anticipated use in Europe once you have access to it in terms of how you're going to manage the eye toxicity, et cetera?
Thanks. I think we have, first of all, unfortunately, we are only 6 million in Denmark, and it's very centralized treatment, and ophthalmologists also, everything is very centralized. So we are doing all the trials where we need ophthalmologists and also outside. And we have agreements with the ophthalmologist, and there is no waiting time, and it happens very regularly. So I don't see that as an issue, at least in the Nordic countries.
Great, Dr. O'Malley.
I think it was easier to get our appointments on trial, right? We both did first in human. We've been working with the drug for 10 years because the ophthalmologist had those appointments for the patients on trial, and then it became available. And I was like, wait, what do you mean? I can't just have you see the ophthalmologist at the snap of my fingers, But they've done some really nice things. One of which is a form that has the Immunogen logo on it. We're not allowed to do that, so we literally cover it up and make copies and hand it to the patient and say, hand this to your optometrist who, Walgreens and Walmart or whatever they have, you have optometrists there. And then if we have a patient with a problem, we'll get them into our ophthalmologist. We literally hand them a paper form, and then with my chart, they can send it back in. With regards to the rebiopsy, we're hearing more and more now that it's commercially available that patients will send the primary tumor and the folate receptor alpha will be negative. And then they'll resend, and sometimes they'll resend the metastatic lesion. And that is then positive. So is that the heterogeneity of the tumor? Is that metastatic versus primary? Is that because it's changed? I mean, these are the things that we will continue to identify. But I now say practically, if you have a patient who's negative, if you sent metastatic, send the primary. If you sent the primary, send the metastatic, and we'll see.
Yep. I want to get to this video because this is a really important topic, as trastuzumab deruxtecan has just been NCCN listed, and a lot of people have never used it. We're going to have a discussion between Drs. Lev and Grisham on ILD.
HER2 testing and anti-HER2 therapy has been an integral part of breast cancer management for the last 25 years, and this strategy, particularly the anti-HER2 ADC trastuzumab deruxtecan, has now quickly extended to lung, gastrointestinal, and colorectal cancer, as well as other tumors, including gynecologic cancers. And while endometrial cancer seems particularly promising, responses have also been seen in patients with ovarian cancer.
It's really nice to have that option now. I'd be really interested to know if there's routine screening that people are doing to look for interstitial lung disease. You know, we worry so much about missing pneumonitis with our patients, and we really don't have like a routine practice, at least in my practice, that we follow for screening for pulmonary toxicity. And I would be really interested to know if others do.
I'm going to ask Dr. Liu to comment on this before we move on, but I think this is such an important training topic.
Yeah, I think this is a really important question to answer. And truthfully, the first thing I did, like when we really got access to TDXD, was I asked my breast cancer colleagues, and I said, what do you do? Do you have guidelines? And what they have been doing is doing CT scans every 6 to 9 weeks, which is what I do. You do not treat if a patient has ground glass opacities at all on the scan, even if they are asymptomatic. That is, we know that that increases the risk of having a bad ILD complication. There's a nice review article actually that was published last year in JCO about toxicities from TDXD, and I've really referenced that to help with my management.
But the challenge with the breast cancer is I think they can get their CT of the chest approved more easily than we can. So I'm having a little trouble getting these regular CTs of the chest unless they have a finding on the chest x-ray. So I look for any indication at all, but I'm really starting to get routine chest imaging with, as you said, every three no more than 4 cycles.
Yeah, we have to move on, but I think just to comment on that, this is very different than mirvetuximab, where we can also see ground glass opacities and things, and you can keep treating. In fact, that's on protocol. So it's very different, mirvetuximab to trastuzumab deruxtecan, the management. And so I think that's a message, asymptomatic, they don't say it's pneumonitis. They say ground glass opacity or inflammatory changes or patchy this. You have to stop. And get it worked up, and then you may be able to restart, but you can't treat through. So that message we just need to keep, I think, singing. I'm going to skip through these questions. I'm going to try and get us back a little bit on time, and then we can maybe come back to some of them after Dr. Mirza's talk. So I'm going to get us back on time so he doesn't have to Zoom. But I'm going to talk about recurrent ovarian cancer, and really just talk about PARP inhibition in recurrent disease and antibody drug conjugates. And so you've heard about this already. We're using a lot of PARP inhibitors in the front line. There are restrictions in the recurrent setting for a variety of reasons and differ globally. But when we think about the recurrent setting, especially in tumors that are becoming resistant, what we are increasingly understanding is there's quite a bit of overlap between resistance to PARP inhibitors and resistance to platinum, although not entirely. But there is significant overlap, and the kind of emerging data from this really comes a lot from the Paula study, which has provided us with a lot of hypothesis-generating ideas because of the robust exploratory work that they have done. And this is just from that clinical trial, but you can sort of just see, I'm sorry, this is from Solo 2, but I'm going to show you some Paula data. You can kind of see how the overlap between a PARP pretreated and a PARP not pretreated patient in the platinum-sensitive and platinum-resistant setting look in terms of response to subsequent lines of therapy. So there definitely is some overlap, and we are concerned about this. And it's not an entire overlap. So resistance to PARP doesn't necessarily equal resistance to platinum or full resistance, but it may compromise subsequent resistance to platinum. And this is from the Paula study, and this is the analysis that was presented last year and a little bit this year, where they looked at patients who were randomized to the olaparib arm and those who progressed during the olaparib treatment and those who progressed after cessation of olaparib versus the control arm. So this is an interesting analysis, and this is the paper that Isabelle Ray-Coukard presented. And it's kind of obvious, like in the red progression-free survival curve, that's the group of patients who progressed on PARP. And the yellow is those who progressed after PARP was discontinued, after they finished their 2 years. And the blue is no PARP. Well, you might say, well, no duh. The patients who progressed on PARP are those who progressed within the first 2 years. So they progressed in a shorter time period. And the other arm is the group of patients who progressed later. And we know that progression-free interval or platinum-free interval is prognostic. And so aren't we just showing the natural history of ovarian cancer and it happens to have a PARP layered on? Probably some of that is true, but there may be some relation to the shape of these curves due to kind of emerging resistance mechanisms that develop when a patient's tumor grows while she's receiving a PARP inhibitor. This is the hypothesis that we really need to explore moving forward so we can try and prevent that from developing in the future. When we see, and so this is the next set of data from that prior slide, that was the initial progression-free interval in those who progressed on or after PARP or control arm. What happens in the next line of therapy? So that's the good question, and they tried to collect this in Paula. So what you can see on the left-hand side is the group of patients who got another line of therapy, platinum, so PBC is platinum-based therapy, and then got a PARP, because there was a lot of PARP after PARP on this study. And so what you can see here is in the red, the progression-free survival curve, this is the group who previously progressed on PARP, and then got another platinum, and they did not do very well, which again just may be their natural history, but there may be some relatedness to the fact that they progressed on a PARP as well. Interestingly, at least in this subset analysis, the patient who progressed after olaparib and then got PARP plus olaparib again versus the control group who never got a PARP and then got platinum and PARP, which is what you'd want them to get, did about the same, which I was surprised about. So maybe we need to validate this moving forward. When you look at platinum-based therapy without subsequent PARP maintenance, that is on the right-hand side, they all do fairly poorly. And that's kind of what we saw from Dr. Mirza's work. NOVA, even in an era where we weren't using PARP in the front line, when you stop the platinum in the platinum-sensitive space, your median progression-free survival was like 5 months. And that's what we're seeing here kind of borne out again, and it really didn't matter between the three arms. So this is hypothesis generating and interesting. It doesn't say the PARP caused this, but maybe it's contributing to it, I think is the question we need to answer. So that's sort of where we are. We have a lot of work to do to figure this out, and I think you heard the discussion about that loud and clear is this is an area of unmet need. Let me finish my talk with just a brief overview of what's really exciting in this space, and this is antibody-drug conjugates. There's so many under development, there's no way I can tell you about all of them, but I'm going to tell you about a few. Starting with the obvious, mirvetuximab soravtansine, which in the US was approved in November of 2022 with an accelerated approval based on the Soraya study, which was a single-arm study, and showed a response rate of about 33% and a duration of response of about 7 months, and so got accelerated approval. So we've had it for over a year. You can see the response rates here as compared to what would be expected, which is about a 15% response rate. And then this was confirmed in the Mirasol study, which was our randomized phase 3 study, platinum-resistant, folate receptor alpha high, mirvetuximab versus investigator's choice chemotherapy with a PFS endpoint. I'm going to skip through this part, just in the interest of time, to show you the primary endpoint, which we met hazard ratio of 0.65, so 35% reduction in the hazard of progression. So because this was positive, we could roll alpha to overall response rate, which was also positive, a doubling, over doubling of response rate, 16% for investigator's choice versus 42% response rate for Mirasol, for mirvetuximab. So because this was positive, we could roll alpha to overall survival at the time of interim analysis. And so for this to be positive, the p-value had to be less than 0.0131. And it was. And so this was the interim OS, but it will be the final OS because it is positive, met statistical endpoints with a hazard ratio of 0.67, so a 33% reduction in the hazard of death, with use of mirvetuximab versus investigator's choice chemotherapy in this setting. And this is currently under review both by the EMA and the FDA for global approvals. Again, it's already available in the US, but we're very anxious that there be global access to this, as there was a global participation in the trial, and our European and Asian patients deserve access to this medication as soon as possible. We've talked about the safety summary of mirvetuximab already with the ocular toxicities. It is very well tolerated with only 9% discontinuations due to adverse events. Very low hematologic adverse events, no alopecia, common class effect GI toxicities that are common but low grade, and the ocular toxicities. About 50% of patients will have blurry vision or keratitis. This is 100% reversible with mitigation strategies, but does require the ophthalmologic surveillance that we talked about. Other antibody-drug conjugates coming in this space are luveltamab tazevibulin, which is another folate receptor alpha targeting agent. Response rate's 37% in folate receptor alpha high, and this has moved into a registration trial. So I think we're watching for this one. Farletuzumab acetarebilin is another folate receptor alpha has a nice signal in early stage and is still dose optimizing, so not quite moved into later trials yet. And there's others coming. These are in phase 1 testing, and these are very differentiated agents, different payloads, different linkers. And so I think we're going to see a nice pipeline of medications for our patients moving forward. I was trying to catch us up, and I didn't. Raludotatug deruxtecan, but I'm going to finish. Raludotatug deruxtecan, or RDXD, I presented at this meeting. This is an antibody-drug conjugate targeting cadherin 6. With a response rate of just under 50% and a duration of response of just under 12 months. This is moving into a global randomized phase 2-3 study led by Isabel Ray-Coukard. So this is coming very quickly to your sites, currently biomarker unrestricted, which is exciting. And then, of course, we've talked about trastuzumab deruxtecan in every disease site. In ovarian, you see the response rates here, they're outstanding. The rates of grade of 3+ IHC ovarian cancer is about 10%, maybe 15 to 18%, 1+ through 3+. This is a small population, but worth looking for to get access to this important medication. And that's what I have right here. And then I'm going to skip through this because I think we can talk about it in the discussion. We've talked about pneumonitis, and we'll get to module 4. So I almost got us back on time. Okay, that's me. Yay, me. Okay. I'm just kidding. Okay, let's move on to the last module, and I think we're back on time, so we can spend all the time that we had allotted to adverse events, which is why I skipped through that, because we'll come back to those slides, and they're all available to you. But let's get to some video vignettes between Dr. Love, Solani, and Bacchus talking about PARP inhibitor toxicities.
Dr. Mirza is about to present some fascinating data comparing toxicities of the available PARP inhibitors, but our consulting faculty had specific clinical scenarios related to these agents they wanted to query you about.
PARP inhibitors we've been using for quite some time now, and managing the toxicities I think has become very routine, but sometimes, I still struggle with fatigue. It's been an issue that patients have. I feel comfortable with anemia, I feel comfortable with, other side effects, GI side effects, but fatigue can sometimes be debilitating for patients. And even with dose reductions and dose interruptions, this can still be an issue, particularly for patients who I feel like will derive the best benefit from a PARP inhibitor. So any tips on managing fatigue would always be welcome.
Within weights and plates rule that we use for niraparib dosing, we certainly see a lot less severe thrombocytopenia early on in treatment, but it still happens. So you still can have that patient who develops a grade 3 or 4 thrombocytopenia and you hold, but I also sometimes get referrals from patients who were completely taken off of treatment after an incidence of grade 4 thrombocytopenia. Can you explain to me how you best manage the grade 4 thrombocytopenia in your practice?
Great questions. Unfortunately, we have the world's expert on niraparib sitting right here to my right. So Dr. Mirza, can you talk to us about thrombocytopenia and management?
I think thanks. That's a great question. First of all, we did this mitigation strategy for looking at the NOVA study results and changed the PRIMA trial accordingly. It has moved us to a much safer way, but still we see grade 3-4 thrombocytopenia. So first of all, what you have to, when you are entering a patient, you should make sure that do not start treatment shortly after chemotherapy. Give the bone marrow time to recover. I usually wait till 6 weeks before I start treatment, not at 4 weeks, not at 3 weeks. I wait 6 weeks. And at that time I start. That also helps a lot. Second thing is, first of 4 weeks, do weekly blood test, blood count, and in case you can see that thrombocyte count is going down under 100, just pause. Come back again. I would. Well, first of all, you have to decide the dose, 300 and 400. That is about according to the body weight. And then I would go one level down. And usually we manage on that and continue the treatment. We have sometimes issues that 100 milligram is also causing thrombocytopenia, and we have to pause. In that case, I would usually switch to olaparib and try olaparib and start to do that. That is for thrombocytopenia. If it is fatigue, I have seen the other way around. I don't know how others have, but I felt that fatigue was more prominent for olaparib and not for niraparib. And I have a couple of patients where I have to switch to even the dose level coming down, switch to niraparib, and they're doing quite well. So I think, remember, you can always, there is efficacy data available both for niraparib and olaparib for a lower dose, which is good to go, but you also have a choice to switch.
Yep, absolutely. Let me get, Dr. Liu, can you comment on fatigue and how you manage, counsel for and manage fatigue? 'Cause that is a hard adverse events to address.
Fatigue is a really challenging thing to address because it's a real quality of life impact. And so I think I definitely counsel patients about it. I think that with the expectation, patients are sort of able to sort of understand it's coming, and that helps. I think that, I do pauses or dose reductions as necessary. But one of the things that actually is really interesting at our site is one of my colleagues, Dr. Wright, has started a study looking at cognitive behavioral therapy. It's a telehealth intervention. It's a 6-week intervention, and she's reported on sort of the initial results, but actually it helps. It's helped patients with fatigue and allowed them to actually stay on a higher dose of the PARP inhibitor, and so that's something that she's looking to sort of continue to develop. It's because it's telehealth. It's something that we think is going to be something that can roll out more broadly.
Yeah. Did you have a comment, Dr. O'Malley?
Yeah, I think, the non-pharmacologic absolutely have to go to our go-to, make sure sleep patterns, I think we sometimes forget to talk about this, right? Exercise. I mean, if we can get our patients to do yoga, what's the one consistent across all solid tumors which is shown to make a difference in tolerance is yoga. It's amazing. It's always positive. I don't know if it's the breathing, the stretching, or what. I'm not a yoga guy, obviously, but it's I think as you look at that, those are great opportunities. But we do have pharmacologic. Methylphenidate, or sorry to use a trade name, Ritalin, can be utilized. Now, I don't like to throw medications, especially somebody who's taking oral twice a day, but I just had recently a patient who is a surgical scrub tech, and we started at a very low dose, rather than the usual 20 to 30. On her, she's very young, we started at 10. She said it changed her life by utilizing a pharmacologic intervention. Somebody who's working full-time going through chemotherapy. And I've used it a little bit with PARP inhibitors. It just feels weird to put another pill at somebody who's already taking, a pill a day or 2 pills, or 2 doses a day. But it can be utilized, and it can be utilized very effectively.
Yeah, that's a great, again, we can talk about fatigue forever, but these are good points. I want to get to AML-MDS, and I want to make sure we give Dr. Mirza his full time to speak. So let's hear from Dr. Armstrong and Dr. Love.
The initial concern about an increased risk of AML and MDS in patients with heavily pretreated ovarian cancer who receive PARP inhibitors has been mitigated somewhat by more recent results of the use in primary maintenance therapy, and Dr. Armstrong has reported an increased incidence in patients with BRCA mutations and seeks your perspective on this important issue.
I would ask the panelists, we have been using PARP inhibitors longer in ovarian cancer than any other diseases. And so we're kind of breast cancer world, the pancreatic cancer world, the prostate cancer world are behind us in terms of how long they've been using them. And we know that one of the cumulative toxicities is secondary AML or myelodysplastic syndrome. And I would ask the panelists how you talk to patients about that risk and which patients you would consider at highest risk for that. I mean, Neil, the data is pretty clear that upfront maintenance, the rates are small. They're higher in the BRCA1 mutation carriers, and they do go up in that, like from Solo 1, it was like 0.8 for the placebo group and 1.5 for the PARP and the olaparib group. So a doubling, but, not very high. But I would also ask the panelists about the duration of PARP inhibitor therapy that they choose to use in the upfront setting. And is that different with different PARP inhibitors?
Dr. Liu.
So I discuss the risk of potential AML or MDS with all of my patients who I prescribe a PARP inhibitor. I think the risk is higher in the patients with a BRCA mutation. I think we've seen that constantly with the data. Are there other factors that can predict for higher risk? And I think that's something we really need to think about. We've asked, is the presence of pre-existing CHIP something that could be a risk factor? I don't think we know. We've speculated on that. And I think that's something where we need more data to come in and really look at that prospectively.
And how long are you using it?
From the front line, I treat to the trial. So if I'm using olaparib, I stop at 2 years. If there's no evidence of disease, and when I'm using niraparib, I do it for 3 years.
Dr. Mirza, I see you want to make a comment.
Yes, I think it's important here. I agree that, and we have to wait for another 5-10 years for the first line to see how the real risk is coming up. But remember, you are talking about increase from 0.8 to 1.5% in BRCA mute population. And you should also remember that half of these patients will not relapse because of this treatment.
Right.
So what is the balance? So I think you have to be very clear with the patient that the benefit is so much that it does not take it to the account. And I completely agree, we have to keep an eye, but this is something we have to talk to the patient.
These are just some of our survey results before we get to your excellent talk. It looks like we're pretty much aligned. Dr. O'Malley, any comments on kind of our panel's assessment of the risk of treatment-related myeloid neoplasms?
Yeah, I think, probably more accurate, I should put 0.5 plus or minus 0.5 rather than 1 without further therapy. But again, if you take that into the BRCA mutations, and remember, is it BRCA, which I don't think we have, it's more platinum, they're living longer, right? If you live longer and get more platinum, you're going to increase your AML MDS rate. So I'm not sure it's anything to do with BRCA than it is the phenotype. And we look at, and we double it, and we are unbelievably consistent at 1.5. It's pretty amazing. And I think the data is really across multiple trials is showing that.
Yeah. This is sort of our estimate the chance of patients who are receiving olaparib maintenance will experience toxicity during treatment that will require them to withhold administration. And what are those toxicities? Dr. Liu, any comments on this? It looks like we actually are a little different here.
Yeah, I think it might be how we think about withholding. I mean, if it's sort of to pause and then to sort of restart at a lower dose, then yes, absolutely, I would agree that the higher estimates, when I think of withholding, I'm thinking you can't actually get PARP inhibitor and that
Yeah, so a little bit confusing. But we all kind of pick the same GI fatigue, anemia, and then those are the big three that we worry about with PARP inhibitors.
Absolutely.
Yeah. We'll do one more, and then we're going to move to your talk, Dr. Mirza. When would you recommend transfusion or dose reduction first for anemia? This is a common question. Someone presents maybe with grade 3 anemia. What are we doing? Looks like we're kind of all over the place. Dr. Mirza, any comments here?
Well, that is something we can manage, and I do not dose reduce. Well, if it is multiple anemia fall, then I would dose reduce.
Yeah,
but to start with, I would do the
transfuse, and if it doesn't happen again, great. If it does, you dose
exactly.
reduce. Yeah, I do the same thing. Absolutely.
Dr. Grisham has the best answer.
Huh? Does she have the best answer?
She had the most complete one. Yeah.
Oh yeah, she wrote a full sentence.
Beautiful.
Those medical oncologists, man, they're We're just like, no. Don't. No. All right. I'd like to have Dr. Mirza join us for the final treatment, or final talk of this session on adverse events.
Thank you.
Take it
and
away.
Thanks for inviting. I think this is a great session discussing. I was asked to talk about the toxicity, and we have actually discussed most of it. I'll just summarize it once again. This is the discontinuation. The most important thing with PARP inhibitors is the efficacy. They have really changed our standard of care for and the outcome of our patients. So we would like to have patients on treatment for the full time. And I just took this one from the front line, that the discontinuation rate is actually not very high. It's quite manageable. Within all PARP inhibitors, I've put GOG 218 for reference here. So I think we are doing quite well with the managing treatment. When it comes to in the relapsed disease, again, you see more or less equal rate of discontinuation. So I think that we are managing PARP inhibitors quite well with the dose modifications, dose interruptions, and then some sort of help. When we look at the toxicity, I'll take it first, the niraparib. We have 3 trials available. Prima trial is the first line, NOVA and NORA are the second line trials. And you can see the hematological toxicity up there. That is probably one thing for niraparib, which is quite obvious, that you have thrombocytopenia, and we discussed already in detail how you are going to manage thrombocytopenia. Anemia is another issue. There is low-grade nausea and fatigue, but my personal experience, because we do both olaparib and niraparib, I feel that olaparib may have a more fatigue and nausea, maybe because of the dosing, because you can give niraparib once daily, they can take it at night and wake up more or less fresh, but here you have to give morning and evening. So I don't know that what would be the case. And here you can see the solo 2, where nausea and fatigue comes on the top. Again, low grade, but it is a concern. When it comes to nausea and fatigue, what is low grade? You're giving treatment every day for 2, 3, 4 years. And low grade is serious toxicity. It's not a lab abnormality. So that's why it's important to, we have already discussed how to manage these things. So this is a very rough way to put it. There are class toxicities which are there, fatigue, nausea, anemia, and thrombocytopenia is much higher in niraparib. There are some LAT and SAT rise in rucaparib. Hypertension in niraparib is also around 10% of the patients, and that has to be managed, and it's manageable. So I think these are the things you can take care of. Then we have very nicely discussed the MDS and AML. In the relapse setting, where you have given multiple platinum treatments and DNA damage, and on top of that you are giving PARP inhibitor until progression of disease, which is much longer than in first line, you have seen higher risk of MDS AML, especially in the BRCA mute population. I really like what Dave, you said, that is it because they are living longer, or is it the real, probably both, due to their BRCA mute. When it comes to the niraparib, you see again in the relapse setting higher toxicity. The one solo 2 you saw, that was only BRCA mute. Here you see also BRCA wild type population. So yes, there is a risk. You have to talk to the patients. I try to convince them after 2-3 years of maintenance therapy that they should stop. It's a decision we have to take together. I would not force that to patients. I will only tell the risk of this, because the benefit we have seen is much more still in this population as well. And in the first line, we have already seen that the risk is much lower, probably because they just had one course of platinum, and that could be the case. But I will very quickly go through the ADC, and I've only taken mirvetuximab because I think that is the first drug entering ADC in ovarian cancer, which is the data we saw was amazing. So what are the mechanisms of toxicity with ADCs? First of all, it's target independent, non-specific. It's the ADC uptake into non-malignant cells. Another could be that's off-tumor toxicity. Target antigen may express on normal cells, and that causes toxicity because that's the uptake. And the third would be the bystander effect, that's so-called off-target toxicity. So these are the cases. You have already seen this slide. I think anything which is showing here clearly different is the ocular toxicity. We have started understanding that quite well. We have at least 2 drugs where we are dealing with that. Tisotumab is in cervical cancer, and this one, and I think we are managing quite well. The most important thing is that you have questionnaires here, go to ophthalmologist, and make sure that you have ophthalmologists available if there is signs, and you have to have the mitigation plan for that. I won't stop on the hematologic toxicity. It's very manageable of low grade. What I call for hematologic toxicity of low grade, this is lab abnormality, unless it's anemia. Peripheral neuropathy is again low grade, but it can be troublesome, so you have to manage that. You should consider that grade 2 peripheral neuropathy, you probably have to dose reduce in that case. Then you come to the nausea, antidiarrheal treatment, and nausea antiemetic treatment. That's again, you have to remember that this may be an issue, although it is grade 1 and 2, but you may have to deal with these toxicities as well. Ocular toxicity, I think we have discussed quite nicely. The thing is that both blurred vision and keratopathy is probably overlapping so much, and half of the patients will have some grade of this toxicity. Here you really need to have a very clear discussion. I think it's we don't have optometrists, we have ophthalmologists. We take care from the very beginning and during the treatment and the minimal toxicity, and you have to pause. There's a very nice paper, how to manage ocular toxicity, published. So I can strongly recommend that you see that. Thank you. I gave you half a minute back.
That's amazing.
This is a world record for you.
Well done.
I have trained.
I've never seen you end before time.
I know.
In SGO, I had to do it in 7 minutes, and that was terrible.
So Dr. Mirza was the only presenter who was on time. So I think we have to give him a round of applause.
Yay. For the first time in his life.
Like first time in his life. Yes, I'm the worst. I was the worst. You were the best. So we have one more case to present. Are we okay to, we'll go a little bit over because it's a nice case. We'll do it. So let's do one last case, then we're going to let you guys get on with your SGO. This is Dr. Lev and Dr. Grisham talking about neuropathy, which is, we just talked about, important side effects.
And finally, Dr. Grisham reminds us that with all the excitement about new agents and treatment strategies, it's also important to keep in mind toxicities of more traditional treatments, including cytotoxic chemotherapy.
Something else that is really something I'd like to see us concentrating on is trying to prevent neuropathy in our patients. I mean, this is so debilitating for so many of our patients and turns into this chronic disease of neuropathy. And every single one of our patients with ovarian cancer gets a taxane with their initial chemotherapy. And then, of course, paclitaxel remains one of our most effective treatments for recurrent disease. And so anything we can do to help decrease that risk of neuropathy, I think will improve our patients' quality of life and also improve our ability to be able to give meaningful doses of taxanes for prolonged periods of time. I've been very interested in the use of extremity cooling and have adopted that in my practice quite a few years ago, just using bags of ice on patients' hands and feet during their taxane infusion, similar to the cold capping technique for hair preservation. And anecdotally, feel that it helps my patients quite a bit. I would love if there was more research devoted to that question.
Or any research.
There is research. There is
On neuropathy?
Yes, there is.
Come on, let's see.
I
In a real journal?
I do the same thing. Like you can get off in the U.S. anyway off of Amazon. It's pretty cheap. You get cold mitts and cold socks. I have all my patients get them.
No, there's one of my colleagues, Rosalind Segal at Harvard, is actually looking at mechanisms of neuropathy that develop that chemotherapy-induced neuropathy. She's identified two potential sort of mechanisms. There's BCL2L2 loss, and then another potential target, SARM1. So there's actually sort of mechanistic research. I think that the cold stuff will be great, but mechanistically, if we understand it,
Dave,
then we could think about
I'm listening. I swear I am. I swear I am. How about management? Management diabetes, undiagnosed diabetes is a great opportunity when they come into our practice that so many of our patients have undiagnosed diabetes. That to me is probably the lowest hanging fruit.
That's an excellent point. Yeah. Okay, well, I'm glad we got through that. I'm a little surprised we got through that last video, but I'm proud of us. Thank you to my faculty. You guys were amazing. And just one last thing, if I could put a plug in. We talk so much about AML, MDS, and in the U.S. anyway, Dr. Elizabeth Swisher at University of Washington has a patient-driven study. Patients can just, from anywhere they are, can scan a QRS card, they get a kit, and they can submit blood. And she has a grant to try and look at these predictors of AML, MDS amongst patients who are going to be getting PARP inhibitors. So it's a decentralized trial for patients in the U.S. And it will be one of those that hopefully helps us figure out who's at risk for a deadly secondary malignancy. Sorry to use my podium to plug my friend's research, but you're released. Thank you so much. Have a great day.